Welcome, everybody. We are here for one of the first in a series of Curing Coma webinars. So the Curing Coma campaign is designed to understand how to best help coma survivors, as we know that it takes a village in order to help these types of patients. My name is Nathalie Kreitzer. I'm an associate professor of emergency medicine and neurocritical care at the University of Cincinnati. I'm one of the co-moderators today, and I'm going to allow our panel to introduce themselves, starting with Brooke, my co-moderator.
Hi, I'm Dr. Brooke Murtagh. I'm an occupational therapist by training and certified brain injury therapist. I'm the brain injury program manager for Madonna Rehabilitation Hospitals and the DOC program manager for Madonna Rehabilitation Hospitals in Nebraska. Thank you for having me. I'm excited to co-moderate with Nathalie.
So we'll move on with Dr. Finz.
Hi, I'm Joe Finz, and I'm the E. William Davis Jr. MD Professor of Medical Ethics and Chief of the Division of Medical Ethics at Weill Cornell Medical College, and I'm also a visiting professor of law at Yale Law School, and I co-direct the Consortium for the Advanced Study of Brain Injury at Cornell and at Rockefeller, and I'm really delighted to be here and also to work with the Curing Coma campaign on the ethics module that we're trying to do as part of the Scientific Advisory Committee. Great to be here.
Thank you. Excited to have you. And Neha?
Thank you so much for having me. And I'm Nathalie Dangaij. I'm an assistant professor of neurosurgery neurology at Mount Sinai. And I'm the co-chair for the community of collaborators for the Curing Coma campaign and serve as a director for research for neurocritical care and recovery at Mount Sinai. And this is an absolute delight to hear from people who've been thinking very, very deeply about what our patients and families need as they go through this journey from acute brain injury to prolonged disorders of consciousness. So thank you for having me.
Thank you so much. And Dr. Kurzfeld?
Yeah, hi. My name is Claire Quartz. I'm an associate professor of neurology and a stroke neurologist at the University of Washington in Seattle. I also have clinical training in palliative care and conduct palliative care research, really, as funded by the NINDS and now NINR as well, around the sort of communication, decision-making, and support needs of patients and family with severe acute brain injury.
Great. And then we also have Dr. Manley.
Hi, I'm Jeff Manley. I'm a trauma neurosurgeon who's been working with acute care and long-term follow-up of traumatic brain injury patients for over 20 years. I also helped to coordinate a large research network called Track TBI, where we've been enrolling patients at the time of injury, and we now have follow-up in some of these individuals out to about 7 years, which I think has provided us with some important insights into the kind of decision-making that we're making on many of these patients, in my opinion, far too soon. So I look forward to discussing all this with you today.
Well, thank you so much. I'm going to start with Neha. So we'll start, just broadly thinking about the acute period of time when we have patients in our neurointensive care unit. So one of the big issues with thinking about prognosis is that there is a great deal of uncertainty in the beginning. And how do you best describe this idea of living with uncertainty and the concept of uncertainty initially when we talk to families?
I think that's a great question. So when we think about everything that happens to patients with acute brain injuries, right from the moment of the brain injury to what's going to happen in the short term and long term, despite all the progress that's been made, there's still a lot of uncertainty. And each individual patient behaves very differently. And how this patient, the disease process, the environment that they're in, the treatments that they get, the rehabilitation that they have access to, and the village that they have access to help them through this recovery, change the outcome for each individual patient, irrespective of the underlying brain injury. That's something that we all as frontline providers have to be very cognizant of and acknowledge it when we're having our family meetings, when we're determining in a shared decision-making model what needs to happen next. So in my mind, the first thing that needs to happen is just acknowledging that there's going to be uncertainty. The second piece is recognizing that some of these decisions that need to be made in a timely fashion are going to be very difficult, and they're going to need to be made with information that is going to change and evolve even over a patient's time with us, as well as while they're in a rehab setting or continuing to recover in a long-term care facility. So that recognition and the partnership that needs to happen between frontline providers, the loved ones, the informal caregivers, stating that need for partnership and being there at every step of the journey, sharing information in an open and transparent manner, and not being concrete in what we think is going to happen, and incorporating what we know from the scientific realm as evidence continues to evolve in how we're making some of these decisions. So challenging that dogma every single time we're taking care of a patient. So I think those are some of the things that I'll do very intentionally when I'm talking to patients and families. And most of the times it's family members or loved ones when patients can't speak for themselves.
Can I jump in? So one of the things that I think we have to be, familiar and recognize is the language that we use: coma, vegetative state, minimally conscious state. Even stroke. People don't know what we're talking about. And Lee Woodruff, in her memoir about Bob Woodruff, the ABC News journalist who had an injury in Iraq, and they wrote a book together. The book is called In an Instant. And in an instant, people are immersed in a place, in a language, in a discourse that is totally alien to them. So it's the issue of health literacy. Our job is really to be doctors, which means to teach and to educate and help families. And so one of the things that, I interviewed over 50 families for my book, Rights Come to Mind, and I heard the horror stories of how they didn't know what was going on. People were talking, but nobody was listening because they were in shock, they were in distress, and they didn't know what we were saying. That is my interviewees, the families. So one of the things I like to think about is trajectories, and Jeff and I were talking about this idea earlier in the week in a different context. I like to analogize as far as prognostication, like how is it going to turn out, what's going to happen, to a hurricane that's coming off from the west coast, from the west coast of Africa across the Atlantic. I don't know where it's going to land as it's just leaving the west coast of Africa. I don't know if it's going to hit Galveston, North Carolina, or New York City. And we talk about the cone of uncertainty. It gets narrower and narrower and narrower as it gets closer to North America. So what I like to do is talk to families about milestones, about things we can look for, hopeful ones and maybe not so hopeful ones, as the disease trajectory progresses. And I agree with what Naya said. Everybody is different. This is not like, a stereotypic disease. Everybody has their own injury, and they're going to behave differently, and they're going to have comorbidities. And so there's a lot of uncertainty. And I think the thing we need to avoid is categorical nihilism, and that it's all going to turn out badly, and a sense of it evolving. It's an evolving story, and having a little bit of allowing the uncertainty to be a positive uncertainty, because it's just as possible as being good or bad. And with all the interventions that I'm sure Jeff will talk about and others, there's more hope now than ever.
Joe, can I ask a follow-up question to what you said? It got me thinking, as you talk about health literacy and the terms that we use with families. So the Curing Coma campaign, maybe a year ago, put out the Curing Coma campaign survey. And one of the questions on that survey was how we as clinicians that work with this population, potentially experts, how do we define coma and some of these terms that we use? And the results of that survey was that there's huge inconsistencies within us as the professionals of how we even define behaviorally at the bedside, and how we diagnose, what criteria we're looking at. So if there's inconsistencies and a lack of consensus within the medical field, how do we even begin to help families understand if we're even struggling to purely understand and define this phenomenon.
Right. And I think, so I mean, you get everything from, well, he's basically brain dead, which is, I'm not sure what that means. And it's not a polite way of talking about people with a disorder of consciousness. And it's not like a fair gloss. But I think we have to be precise in what we're saying. Also, even the Curing Coma campaign as a title, we mean it as the things that begin with a coma, but can evolve into these other brain states. And to add to the complexity here, and we're getting a little beyond ourselves, but it relates to assessment in the ICU and early on, is all of these categories are descriptive categories of phenotype, of what the patient manifests at the bedside. But what's going on inside their head might be something quite different. They may have covert consciousness. I'm thinking of the work of Jan Clausen with the EEG or Brian Edlow with the fMRIs that show covert consciousness, which is a phrase that my colleague Nico Schiff came up with originally, and cognitive motor dissociation, which has a whole different prognostic thing. So it's not only what you see, it's what's actually going on, as it were, under that veil of the skull that may be the most prognostically important thing. And that's what we're beginning to interrogate to understand those prognoses.
That's a lot to take in, and it's very interesting to think about. As we sort of think about, just sort of how we're limited with some of these definitions ourselves in the medical community, or how we, sort of have shaped people by those definitions. I just wanted to tap on something that Dr. Creutzfeldt has described, and this is the idea that, we all have biases about prognosis as we're talking to families. And what recommendations do you have for us to start to really recognize and learn from some of these biases? And, some of the ones that you've written about are the idea of recall bias or forecasting or disability bias.
Yeah, very, very important. And I think go with this idea of prognostic uncertainty. And I really like the title actually of this webinar, which has prognostic humility in it, which calls on us as providers and prognosticators and communicators in being humble about what we know and what we think we know. And it's actually akin to what Danny Kahneman in this new book, Noise, brings up, which is actively open-minded thinking. I think that's probably what this prognostic humility is, which means trying to actively delaying our intuition or what we think we know as long as possible while we gather as much information as we can. And then we can use our intuition and provide judgment with this open mind. So I think that's sort of a way of mitigating. And then as we talk about biases, of course, now we also need to talk about noise. So noise being, as they in their book define it, as the unwanted variability in human judgment. And there's a lot of that in there, of course, what we're talking about. The biases that we've described, for example, in effective forecasting. Effective forecasting is yet another dimension of prognosis, which is thinking about how someone might feel in a certain situation. So even if I have a certainty, maybe I know that they will be dependent on artificial nutrition going forward. So then can I predict, or can a family member predict, or might they have even been able to predict in the past how they would feel about it? Like, effective forecasting is something that I think we all do all the time, and get it wrong all the time. Just think of maybe the dinner that you didn't want to go to with a friend or not friend, and you thought you wouldn't enjoy it, and then you actually did, or the run that you didn't want to go on, and then you did, and you enjoyed it. So that's all this effective forecasting, and so being aware that we're not good at it. And then you mentioned the disability paradox, which is probably a bias within this effective forecasting. So well described, especially actually in spinal cord injury, because those are the patients that we can ask later. Our patients we often can't ask even later because they're so impaired. But the disability paradox, meaning that a non-disabled person will judge a disabled person's quality of life as much poorer than that disabled person actually does. I think you asked also about how we mitigate these, or how we communicate them with our families. That's, I think, what's important. And that brings this actively open-minded thinking. And again, so the first step, like Neha also said, is acknowledging that there is uncertainty, and that there is uncertainty on our side regarding recovery. And even families who think they might know that you would never want to live like that, I think reminding them also of the disability paradox, and reminding them that, you know, I've said to families, you know, it sounds like he's a really, you know, avid hiker and someone who really loved his independence, and you're having a hard time imagining him dependent on anything. You know, it's just also important for me to tell you that we have many patients who actually adapt to new dependence or new disability, and just to add that to the information that we have.
And if I may just add a comment to that, just preparing the loved ones, the family members, for this new state of normal. It's not going to be who this person was before they became our patient. It's just going to be different. It's not going to be bad, or it's not going to be better. It's just going to be different. And that trajectory, going back to what Joe was saying, that trajectory of what's going to happen at different points in times, what those milestones may look like for this particular individual are probably going to be different as compared to your friend who had a stroke or somebody else who had a cardiac arrest. We rely a lot on our own experiences as we're prognosticating. We're relying both on the patients that we've seen as well as what literature has taught us. But I often tell families that, you know, I try to be an expert in what I'm doing, but you are the expert in this person, the human being behind the patient that we're seeing in front of us. So whatever decisions we're going to make is coming from that place of love for this person. So we take all of that, and you're an equal partner in this decision making. And some of Suzanne Michegel's work and David Huang's work, and trying to piece that story together as much as possible, and being an equal partner in that decision making with all of that uncertainty, and living with that uncertainty, letting them know that, you know, this is not your burden to carry alone. We're doing this together, and we're not going to be abandoning you after your stay in the ICU, but there is a whole continuum, and that feeds into the realm of critical care recovery clinics and our partnership with our rehab colleagues and so on and so forth.
Dr. Manley, can I pose a question to you?
Sure.
As we're, you know, talking about, you know, we don't know the trajectory, you know, on day one, what this individual is going to look like, you know, 1 month, 4 months, 6 months or more down the road. However, in hearing this, and we're all saying similar things, I can't help but think of the literature that I've read where, you know, 70% of brain injury deaths are because of withdrawal of care and not necessarily because of the severity of the injury. And those deaths are occurring, you know, sometimes as early as 3 days post-injury. So what is your perception, thought? Have you seen a change in practice in your 20 years of trauma surgery and experience, you know, with this, to me, really early, you know, pretty finite prognosis?
Yeah, it's a curious thing. I mean, I've been doing this for a long time, and I certainly, you know, have had different perspectives on this over time. So when I was a resident, there were a number of people who actually died from their traumatic brain injury due to cerebral herniation, because even today our ability to control brain swelling is limited, and there's still controversy over things like, do we use mannitol or hypertonic saline? And, you know, we were part of an early group of folks that went back and started resurrecting this thing that had been done in the 70s called decompressive hemicraniectomy. And it's a pretty simple idea. You know, if the brain is swelling and you can't control the swelling, then you just increase the size of the container where the brain is swelling. And what that did is it led to a phenomena where actually very few people die from their brain injuries because they don't have, you know, profound cerebral herniation, brainstem compression. And so that puts you as a neurosurgeon in a very unique position because you're making a decision based upon a CT scan and a fact pattern, which all of this does not really fit into any meaningful prognostic model as far as I'm concerned. And so we have the ability to prevent death from traumatic brain injury, but we have no ability to predict who recovers and who doesn't recover. And I want to be very adamant about that. I've taken care of thousands of patients. I've had more than my share that I would ever like to go back and think about of end-of-life discussions with patients' families. And what I can tell you is that, you know, some people consider me to be an expert. And as an expert, if I will take that mantle, which I really don't want to because I'm a humble guy, and my field humbles me every day, is that I have no idea. Okay, I mean, yes, if somebody's shot right through the brainstem and it's blasted and everything, I mean, yes, there are some things that, you know, I can even say with that. But I would say that the majority of things that I look at, I have no idea. So then you have to then think about the fact, okay, so we can prevent death. And then what do these patients look like immediately after we stop them from dying? They look terrible. Okay, so if your belief is that, okay, well, I came in the middle of the night, I did this decompressive surgery, now it's day 2, day 3, oh my gosh, what have I done? These people look terrible. So I think what happens is because getting back to this idea that Joe and I were talking about earlier this week about trajectories, we're looking at things at a point in time, and there is a trajectory that each individual patient has. And yes, you can start clumping some people here and some people here, but the fact is that we don't really know. And I've seen enough people that I thought would do well that didn't, and people that I thought that were going to do terrible that did, that I've really stopped prognosticating. So I think it's a delicate walk that we do with families in that we don't want to provide false hope. We don't want to be overly nihilistic. And, you know, really time is the great teller here of what will happen. And what I fear today is that we are making these decisions far too early based upon a series of facts that are in front of us in this acute period that may or may not relate to long-term outcome in these individuals. And so it becomes a self-fulfilling prophecy if you're there at the bedside and it's day 3 or day 4 and you say to yourself, boy, this person looks terrible and, you know, I think we should go ahead and withdraw support. Well, it turns out that most of these patients that are profoundly injured cannot actually support themselves without the advanced critical care that we use today. And so you withdraw support, and within a period of time they pass. And, you know, you sort of walk away and you go, okay, well, yeah, I didn't think this patient was going to do well. We withdrew support. I've seen so many patients where just simply waiting another week or 2 weeks, particularly patients that have a component of DAI, which in most places we never even look at. I mean, if you have a stroke, you get an MRI scan just like that. But to think about getting an MRI scan in severe TBI patients, it almost never happens. And yet, you know, you go in and you look and you see this patient and, you know, we're using the GCS, which is a great, primary tool to stratify patients, but it doesn't really, it doesn't solve every problem, is that, when you see people with a profound amount of DAI, people are like, oh, well, they're not going to do well. Well, I mean, our work, because, our study was one of the first studies that started looking at patients from the time of injury all the way out to many years, would suggest that, in fact, a lot of those patients wake up. So I guess what I would say is that, when we put together the best practices for TBI through the American College of Surgeons and TQIP, we did have a prognosis chapter, and we're going to go back and we're going to basically redo this in 2022. But we said you should wait at least 72 hours. And I actually found it a little scary that when you go back and you look at the TQIP data, that a lot of people are now passing at 72 hours. So now prior to that, it was sometimes at 24 hours and 48 hours. So that needs to be moved out significantly. And we're now having the kind of data to support that. So, my colleagues, Mike McCrae and Joe Giacino, just published a paper in JAMA Neurology out of track, demonstrating that, that yes, those patients all look terrible at 2 weeks. So if you think that you operated on somebody or you provided critical care and this patient looks terrible at 2 weeks, you're right, okay? But what you're wrong about is that those people look terrible at 6 months and those people look terrible at 12 months. There is a substantial subset of patients, and you want to put this in context of any other neurological disease that we deal with, brain tumors, Parkinson's, whatever. There is a substantial subset of patients there that go on to have remarkable recoveries. And the last thing that I'll say is that, you know, the beauty is in the eye of the beholder, and we as clinicians have a very different view of what a good outcome is versus what a family has a good outcome. And we need to spend more time talking to families about what their perspective of long-term outcome is. And I lied to you, one more thing. But the final problem is that yes, we can save people. I think people do better than we think they do. I think families are actually happier with the outcomes of patients than we believe. And I think the main issue that we have to work on now over the next decade is not just simply curing coma, because I think in some ways we can stop people from dying. We can bring them out of their comas. We need a system of health care to take care of these patients, and it does not exist. I want to say that again. We need a system of health care for these patients, and it does not exist. When you come into my hospital, I just talked about decompressive hemicraniectomy. I just got something from our hospital where one of my patients has a bill for $2.6 million, okay? All right, so I've got a blank check as long as you're in the acute care arena. But now watch me try to get that patient into the kind of rehab that that patient needs. My chances of doing that are maybe 1 out of 5. So this is something that we have to fix in this country. It's wrong, and we've got a lot of work to go, a lot of work to do and places to go here. But I think one, we need to stop the nihilism, and I would say that we don't withdraw support on anybody now, for at least 14 days, and even that may be too soon. So I'll stop there. Thank you.
I just want to add, Claire, you want to go first, or?
I think I have 2 quick things just to say, because I think we don't even have the ability or good ability for something cheap after they leave. So, I would argue that rehab is sort of expensive, even though they totally all deserve it. But even seeing us back in clinic is so difficult, especially people who are impaired and in nursing homes and things. Like, we just don't have a system for that. So that, I think, is huge. And then I also wanted to just expand what you said to the other to other neurological catastrophes like stroke and cardiac arrest. And I think cardiac arrest is a really interesting one, because everybody always thinks everybody thinks that we have so much certainty. And even there, if we really let people go for longer, they recover.
So I just wanted to say that I think it's really important to understand the cultural context of the nihilism and the forces that move us to these early withdrawals of care that are scientifically probably, unjustified, because the process hasn't played out. And there are 2. One is, I think, the cultural bias. And it's important for all of us to remember that the right to die in American jurisprudence and American medical ethics was built on the backs of the Karen Ann Quinlan case, Cruzan. So it was in the state of people in the vegetative state who were not going to get better, that the moral warrant for the right to die, to remove life-sustaining therapy, was established. And it's important to realize that not all the people that we're talking about are irretrievable in the same kind of way that those patients were. And we can't generalize that nihilism for those patients to patients that Jeff is seeing on day 2 in the ICU. The second issue that I think is really important is how doctors think. Most doctors are not used to this population, and most doctors are terrified by unconsciousness. When a patient becomes unconscious in the general hospital because they have end-stage cancer or end-stage Alzheimer's disease, or had a bad heart failure and they're hypoxic or whatever, that's end-stage disease. But the same unconsciousness that is the end of life for those patients may be the beginning of the recovery process for our patients. So we draw a false analogy. Most patients are made DNR in the general hospital by surrogates when they lose capacity, when they lose consciousness. So we can't look at patients who lose consciousness in the ER or acutely in the same way. But I think many doctors have a hard time disaggregating that. The last point is that there's a remarkable emerging literature about how injured brains recapitulate the developmental process with sprouting and pruning of axons that shows not only the ability to recover acutely with the intervention that Jeff talked about, and as the swelling goes down and the like, but also have structural changes. That is a recapitulation of normal development. And one of the things that I've written about, and others as well, is if that process takes years and years to happen, it's been documented with longitudinal studies, then rehabilitation has to happen over years and years and years. Just like education accommodates the developing brain, rehabilitation should accommodate the trajectory and the time course of the recovering and recuperating brain. And finally, Jeff was talking about the $2 million price tag of the patient who had acute care injury. The reality is that we make a moral, not only fiscal, but moral investment in these people. And if we're not going to pay for the tail of the cost, which is going to probably be lifetime equal to what the acute care cost, the first 6 weeks and the next 20 years probably cost the same thing, then we should never let a neurosurgeon near any of these patients. And of course, we never would want to do that. So I think we have a moral obligation to have kind of fiscal symmetry so that the acute care and rehabilitative process has equal access. Otherwise, we really are not serving our patients well, and we're not capitalizing on all the great work and the life-saving interventions that happen on the front end, because the back end is equally as worthy and maybe more important for recovery.
Joe, can I bring up, for example, the time-limited trial? I think we're talking about something like a time-limited trial, but we haven't really defined it very well. I also don't think that our families ever hear it. So I think that often our patients leave sort of on the never-never plan, and that I don't think is right either. I think we do need to provide them with anticipatory guidance. This is what I'm expecting to happen in the next couple of weeks, couple of months, and so on. And at every step of the way, we can readdress your goals and your values and your most likely prognosis. And just with that, I think at the very beginning and do everything neurosurgically and critically care possible, and then after 2 weeks maybe make a decision that this was enough of a time-limited trial. I mean, we're not talking about specific cases today, so I think as a general rule, I am totally on everybody else's page that we need to give everyone much more time. But there are individual cases where sometimes the time-limited trial is only a couple of weeks or less.
I would just say that one problem we're getting, the minimally conscious state, unfortunately, doesn't behave that way. And most things in medicine, the longer you're sick, the worse it's going to be. Right. You don't recover from your trilobar pneumonia, it's not going to go well. But some of these brain states are networks that are present but underactivated. And so we it doesn't function that way. There are people who have been in the minimally conscious state for decades who recover consciousness because they got a drug or they got stimulated with neuromodulation. So I think one of the problems is we know how you tap out if you've had hip surgery and you get to a certain point in rehabilitation. We know the trajectory of that. We don't know the trajectory of that. So it's really hard to say that it's too long. We don't know how long is long enough. And so I think it's really, and that's hard because we don't have, and that makes reimbursement very difficult too, because it does seem to look open-ended. But I think, brains recover by biological mechanisms, not reimbursement criteria. And so we need to kind of learn more about the biology to harmonize the financing to go with the science. Right.
Yeah, and that is, we aren't there at all, unfortunately, which puts us in such a dilemma when wanting to give a patient more time and also realizing that they're going to really struggle and the family is really going to struggle financially. I think that makes it very difficult.
Right. And then going back to Jeff's point about a systems of care approach. In TBI, we have the model systems of care approach. In stroke, to some extent, I think we made some headway in terms of stroke systems of care. But again, the input for that system, the acute care side is so much better as compared to the long-term longitudinal care. And creating a system that is patient-centered and not resource-centered. when we talk about some of the resources that go in, that are needed in resource limited settings for providing even some of these time limited trials of general critical care, and then we tag on acute neurological injury and critical care, and then what does it take for that kind of resource limited setting to support patients for several weeks, months, and even years. Is that feasible? Is that possible? We don't want to be in a situation where we have to think about the delegation of specific types of resources. We don't want our care to be guided by those resources. And the second that makes it even more complicated is the evolution of literature and how quickly our evidence and our understanding of what is possible is evolving. So sometimes to make a peace with some of the decision making and the withdrawal of life-sustaining therapies, I think about we're making the best possible decision with the knowledge that we have at this moment in time. Mm-hmm. And perhaps when we go back to the same decision a year or more, we're probably going to make a different decision. So we, at some level, have to make our peace with that. And while we want to be able to think of everything that we can do for a patient for neurological recovery, all the other comorbidities, the medical complications that pepper that trajectory, and how do we prevent those from happening in long-term care facilities? We don't really have eyes on what's happening to our patients. And taking a leaf from the critical care recovery literature, the post-ICU recovery clinics and post-intensive care syndrome, and what can we learn from some of those systems of care that are evolving now? There's so much synergy in what's happening for different diseases, ARDS, acute respiratory failure, for different reasons of being in a coma, cardiac arrest, TBI, stroke, that at some place we will reach a stage where we have that kind of system that Jeff alluded to, where we are able to provide the same level of care irrespective of what the resources or where somebody is coming from, irrespective of the underlying disease process, but we're just not there yet.
So what I'd like to say is that, if we look at cancer today, and if I had an event, I went to an emergency department, and then, they did some imaging that was suggestive I had cancer, there is a care program for me through either, cure or death, right? And I mean, it's pretty comprehensive. We don't have that for traumatic brain injury. Nobody owns this disease. So here we've got the Neurocritical Care Society, coming in and doing curing coma, but there's 15 other different groups of people that touch these patients. Just to give you some data, looking at TRACK, which was done at 20 of the best trauma centers in the country, by 3 months, only 40% of these people had been seen by any kind of clinician, and only 6% of them had been seen by anybody that knew anything about TBI. And so where you live is how you recover. I think that there's a lot of room for improvement in acute care, don't get me wrong, but we've done a lot of work over the last 20 years in acute care, and I think that you can show up at most level 1 trauma centers and get what you need, and some places are better than others, but that is not true once you leave the door. And so we've really got to do a better job. And one last thing I would say, coming back to this idea of prognosis and our nihilism at the beginning, a lot of my colleagues, and I'm speaking now to anybody who's in a position to make a life-death decision in the middle of the night, if you think that you're making vegetative patients, you're wrong, okay? Because one of the things that we've seen in our own institution and what we saw in TRACK is that by a year, people have either come into some sort of, significant disability or some various levels of recovery based upon the GOSE. We didn't see anybody in a vegetative state, because I think by a year, people are declaring themselves. And Joe mentions not really, because there are some people that are out far past a year that recover. But by and large, if you're not going to do these operations and you're not going to, if you're thinking about withdrawing support, what I would say to you is that when you let those patients live, let those patients live, because we're withdrawing support and we are aiding in their passing away here, is that you're not going to make people that are vegetative. So you should not be afraid of that people either recover or they get to a point where the families are going, well, they're not going to, and then they let these people pass. So.
But Jeff, sorry, I think that's I think where it does get difficult sometimes. And I do think that it sounds like maybe most of your families were lucky and had someone to to talk to. We interviewed lots of people at 6 months who still thought, or even 12 months afterwards, and they still thought there was so much uncertainty about their comatose patients. And 6 and 12 months is a time when there's much less uncertainty, but they hadn't been educated about it. And I think that's really where we are, as we've said before, failing people. And I also want to advocate, I somehow feel like it is still just of vital importance to keep addressing patients' values in here and trying to get them in family values. And I do think that there are sometimes certain things that we can be relatively certain about. And just as an example, I'm certain that this is going to be a very long road. And maybe, let's say, for your 80-year-old, let's make it a little easy for all of us. Let's just, for your 80 or 85-year-old grandmother, it's going to be a very long road in a nursing home. And it's quite possible that this 85-year-old grandmother might have said, don't take me there. And that's okay too. So just, I think we have spent too much time in nihilism, that it's now time to put that away and really know what the possible outcomes are going to be. And I also think that there are people who don't want to spend those 3, 6, or 12 months trying to recover, even if
no, and I agree with you. And what I tell folks is that, and this is based upon my personal experience and some of the research that we've done, it really takes 2 to 3 years for somebody to really see where they're ultimately going to land from a really profound brain injury. And I'm talking about people that from all outward appearances appear to be recovered, but in fact are still working on a ton of stuff. So I try to, be empathetic. I try to be supportive, but I also try to educate and be very realistic with the patients that we take care of about what these trajectories of recovery actually look like and what is, the level of disability. And maybe what we're talking about is somebody that can be independent in the home for 8 hours a day. And what does that look like and what does that mean? So, I certainly, I think we don't do a good job educating patients because in general we don't like to have these death and dying talks with folks, and therefore we don't do a good job with it. I mean, to me, I would go back and say that the most important thing that I really think that I do in my career is that talk with that family, and I really value the time that I spend doing that, and I think about it and I worry about it more than anything else that I do, whether it's my research career or my surgery or anything else. I think that's probably, if you said to me, Jeff, what is the hardest and most important thing that you do, it's that talk that we have with those families.
And I think that, it's important to maybe think about this as in the paradigm of informed consent and informed refusal, with the emphasis on being informed. And if we don't know something, we say we don't know something. And I also think there's a role, and this is where Curing Coma comes in, developing biomarkers that help us prognosticate to take out some of the uncertainty. So Jan Claessen's EEG study, the volitional study in the ICU, people that were able to follow volitional commands in the ICU had a 1-year prognosis that was better than those who couldn't. Logical, but before you had that data, you didn't know who was who because they all looked the same. So I think part of the approach here is to get better data that can help decrease that cone of uncertainty so we can get better information. And I also think we have to be less obsessed with the diagnosis and more concerned about the functional status. Like, what would your loved one have wanted to do? Whether they're going to be MCS plus or minus or in the vegetative state, and we really don't know, and it's going to take time to evolve. What was their values in life? What kind of situation they want to have, and give it time to progress. Give families time to make decisions, support them, and I think we have to make sure that we don't cause iatrogenic deaths, either through the avoidable urinary tract infection and bed sore and pneumonia, or the lack of provision of an assistive device that might give somebody the ability, simply putting your hand over a trach so they can talk. Now that we know they can talk, before that they couldn't talk, so we presume they couldn't think. They just didn't have an outward vector to express their consciousness. So I think we have to. There's some mistakes and errors and omissions that are avoidable, that can take some of the complexity out of the choices. They'll still be difficult, but we should avoid the avoidable mistakes. And if we did that, we'd be halfway there, I think.
I'd like to talk a little more about that iatrogenic death, and also something, Brooke, you said very early on, which was the data. We know that the vast majority of people who die in the early stages after severe acute brain injury die after withdrawal of life-sustaining treatment. I hesitate to say that they died because of the withdrawal, because they also are only alive with it. And, you know, just my example of a recent 93-year-old woman whose daughter, and I talked to the daughter and I said that, you know, I think putting even an PEG tube, an NG tube, giving her artificial nutrition may not be in her best interest, even though I think there's a possibility that eventually she will reach a certain milestone. And so you could argue that she died an iatrogenic death because we didn't provide her with artificial nutrition, while I would actually in this case like to say that she died a natural death, and we avoided artificial life support.
I think what Brooke was saying is the Turgeon paper from CMAJ that said that, you know, like 70% of people die from a decision to withdraw care. 31% or so of all TBI patients die. But it was in the context of a decision to withdraw or whole care before we knew what the potential outcome might be. Some of those people were going to die eventually. But I think what that paper was about was it was reflective of this kind of, you know, the nihilism. You know, I love to cite a paper by Dr. Vijix that was in Neurology, ironically, the same journal that published the new guidelines in 2018 that were revelatory and more forward-looking, where he gives, the title of that paper is called The Family Conference End-of-Life Guidelines at Work for Comatose Patients, which is a, you know, a short-term thing. And he talks about families who are unconvinced about the futility of care. And they need to be educated that withdrawal of care is more commensurate with the neurologic status. You know, like we don't necessarily know that so acutely. Now, the book I wrote before the book on brain injury was on palliative care. I'm a big proponent of palliative care, but just because you have a brain injury doesn't mean you should get palliative care. And I think that it shouldn't be reflexive. I also, as an internist, I sit on the ethics committee of the ACP, American College of Physicians, and the ethics manual had clumped together the vegetative state in the end-of-life care section of an earlier edition of the ethics manual. Why were they there together, right? Because of this historical association. And I think we need to preserve the right to care and affirm the right to care and preserve the right to die, and make sure that it's happening to the right group of patients. I mean, you know, families have a right to make these important choices. They need to be informed, but just because you have a severe brain injury doesn't mean you're going to die or that you should die. And I think we need to kind of calibrate that.
No, I'm all for that. And I think my only, you know, the only wording I wanted to say differently was that even in Turgeon's paper, people died after life-sustaining treatment. And some would have died anyway, just like you said. And so it's just a small language thing. The other small language thing is, of course, care. We will never stop providing care. It's more, but what we're talking about here is life-sustaining treatment, or I think Jeff is calling it support or life support, that they were withdrawing. And then I guess the next thing that comes from a language perspective is palliative care. You know, if the term palliative care has also evolved significantly in the past few decades to not only include end of life and quality of dying, but also quality of life and providing additional support. And so I think that is another big challenge of ours. How can we integrate palliative care into the care of these patients and families and support them better going forward?
And I think, you know, the palliative care, you know, they say the unit of care is the family. And I think that's certainly true for families that have been touched by brain injury. And I even proposed once years ago in a paper that most people are not near brain injury centers, and that hospice should learn how to provide respite care for families to recharge their batteries, not because people are dying and they need to go to hospice, but families need to be recharged, and the biopsychosocial and some of the medical support in hospice could be rejiggered, as it were.
Great
to
idea.
help this families.
Yeah.
But I got shot down by a leader of a brain injury organization because, that means you think these people are dying. I said, read everything I've written. That's not what I'm saying. I'm just saying structurally, if you live in the middle of the country and you're not near, one of the, Spalding or Tier or one of those places, where are you going to go? There's nowhere to go, which gets to your point, Jeff. There's nowhere to go. There's no heart in the heartland, and for brain injury, and that's a problem.
Right.
So we need to decentralize the services.
Telehealth, palliative care.
Yeah, I think that's a great point. And just sort of listening to all three of you about the whole spectrum that we are put in this position of honor and privilege to provide care for the patient and the family dyad. And we're in turn, what we are charged to do is very, very difficult, synthesizing all of this information and translating it in a language that's going to be understandable at that moment in time, in a cultural context, in a resource-specific context that is still going to be patient-centered. And to Claire's point about bringing care back to the goals, values, and wishes for a person who can't speak for themselves, and if it's a life well lived, and they would not want to take that chance to see what would happen next, in that moment in time, I think our role as being those facilitators of a dignified death is also as important as facilitators of a dignified life. And for very, very long in neurocritical care, it almost seems like we'd always been riddled with this nihilism. And as our pendulum is moving to a more positive, meaningful direction, making sure that we don't swing the pendulum too far and then settle somewhere in a good balance. That's also our charge. So I think being part of the Curing Coma campaign is really opening up doors to cross-collaborate with so many amazing, incredible people and learn from all these different fields and not just be restricted to who we are and what we know for a specific disease process. So I think it's a great time to be alive, to be learning from all of you and to be collaborating with all of you. Nathalie and Brooke, over to you.
Yeah, absolutely. Go ahead.
Sorry, maybe not a final point, but to add what Dr. Finz was saying, being in Nebraska, in the heartland, but no, he makes a great point of, there isn't a great, if you're not near a system, you're kind of out floundering. And I think I would love to see the Coma campaign also have an initiative, like what we're doing here, we're hopefully educating professionals, but that system of care, having professionals down the line. So I'm a post-acute care provider. There's so few of us, and unfortunately I'm finding this out the more and more I'm out there talking about coma and disorders of consciousness and how we treat these patients to promote that recovery. There are very few providers that understand how to support recovery for these patients, whether they're a physiatrist or an OT, PT, speech therapist, those direct care providers potentially, but again, these patients could end up in a rehab facility, but more likely a skilled facility or long-term care, and they're coming into contact with providers that quite honestly don't have a clue how to support them in that long-term chronic recovery phase. And so I'd love for the campaign to have an arm to be able to look at that as well, because we are saving these lives and we've talked about that trajectory, but then how do we get the providers and the care and the resources in place throughout that trajectory that have the knowledge base and the skills to provide quality care for these patients.
We have EMTALA going into the hospital, right? We don't have EMTALA leaving the hospital.
That's another.
And this is a soft infrastructure bill, building the infrastructure so that Brooke in Nebraska has a comprehensive panoply of services when somebody gets discharged from Jeff's hospital. That's really what we're talking about here. And you know, there was a report several years, maybe a decade now, called the Mohonk Report that I'd urge people to look up that we wrote. Joe was involved with it, Joe Giacino and the Brain Injury Association of America and the Congressional Brain Injury Caucus, where we talked about a spoke and wheel kind of model where there was a regionalization of services. You know, every state has a great medical center. Nebraska's got a great medical school. That could be, you know, part of that system, but they have to take it on, and it's going to be a loss leader. It's not going to make money. Mm-hmm. But I want to make one last point, and then I'll cease and desist. This is not just an economic thing. This is about civil rights. This is about the rights of people who have severe brain injury to fully engage in society. And I personally have argued, and I think that this is a violation of the Americans with Disabilities Act. This is the only segment of our population where people are segregated. People are in places where they shouldn't be, where they can't get the services they need, and therefore they're unable to integrate with their families and their communities and have access to all the other goods that our civil rights enable for the rest of us. So I think it's not only a fiscal argument, it's also a legal argument. And that's why my book was called Rights Come to Mind, because I started off writing about sort of the healthcare economics, but that doesn't sustain it. It really is the rights of these people. And because consciousness is central, it's like, you know, it's giving people the ability to communicate. For them, functional communication is the same as a ramp on the sidewalk where somebody's got a motoric disability that allows them to integrate. The only consciousness we know is our own, or if you're talking. And then I can infer you're sentient and you're sapient. So we need to restore that ability to engage with the other. That's what's critical. And I think that is more than a fiscal concern. It's a moral concern, and it's a legal imperative.
You know, I don't know that I can top that, and I'm not trying to top it other than to top it for our patients. And I would agree with Joe 100%. This 3-hour rule that's applied to our patients is a violation of the civil right. This is a mechanism by which to basically not provide care to these patients. There's a whole lot of other diseases that we don't provide that to. There's a whole lot of folks with cancer that could never fit into a 3-hour rule, yet we continue to take care of them. Why? Because it's the right thing to do. And we are doing the wrong thing today, and we have a set of rules that I agree with Joe 100%. We're violating these folks' civil rights, and they need to be changed. Joe, your idea of an EMTALA for post-acute care is exactly what we need. Bravo.
Oh, such an important paradigm shift, and hopefully this will move everything in the right direction. This has been wonderful. This has just been so exciting. I have learned so much in this past hour. I know that all of the people viewing this are going to learn so much, and I really, really appreciate everyone taking the time and having this discussion, and hopefully future Curing Coma webinars can continue in this format. This was wonderful. Thank you all so much.
Good morning, everyone. Almost afternoon. Thank you for joining us. So let's kick it off with questions. I'm going to go into the chat here. Natalie, is that good for you?
Yeah, sounds great.
So it looks like our first comment and question is that no matter how many great biomarkers or tools we have to develop or increase the statistical precision, I'm not sure if that means diagnosis or prognosis of DOC and severe brain injury, but if we don't invest into understanding what acceptable and effective communication strategies are, those tools are unlikely going to translate to better clinical decisions at the bedside. How do you address optimistic bias, desire to keep hope, and distrust in how well doctors prognosticate?
Who do you want to go first? I'll start because I think we're all
whoever is brave enough to go first.
Well, first of all, I don't think we're advancing an optimistic bias. We want an honest bias, and I think the headwinds are such that there's a lot of negative presumption. There's nihilism in the background, and I think a lot of this is contextual. What people are able to achieve depends on the care that they receive. As Jeff said in the video, I think he said something like, you know, the care you receive depends on where you live. So it's highly dependent on that. You know, in the very, you know, end of the preface to my book, I wrote this like sort of like exculpatory like paragraph or two. I said, I'm not advancing this kind of brain state. I'm not trying to say that anybody would want to be this way. But I think that our obligation is to meet patients and families where they are. I think Claire was saying this in the video as well. Understand their values, understand what an acceptable existence is, and then try to provide them with the resources that make it possible, if it is possible, to achieve those goals, and also give people time to have it play out. I think one of the challenges that we encounter is, and I think Claire brought this up as well, you know, is how much is too much? How open-ended is this? You know, and how do we understand time? And the Greeks had two conceptions of time. They had chronos and kairos. Chronos is like, what time is it? Kairos is it the right time to do something? So how long does it take to get to grandma's house? And is this a good time to visit her with COVID going on? And the Greeks also said that chronos precedes kairos. In other words, kairos is the moral choice. And before you can make a moral choice, you need to have a sense of your facts. And one of our challenges is we don't have the chronology. We don't have the chronos of brain injury yet in hand. So we're forced to make these moral choices before we have all the facts. And that makes it so much harder. And it makes this, you know, sort of pregnant within in precision and uncertainty. And frankly, you know, all we can do is be honest and transparent and say we just don't know. And again, the time trial idea is helpful. And I would say, you know, be generous in the time trial. And again, work on functional status and less on sort of the diagnostic precision, because our diagnostic categories will change too. We're not going to be calling these things what we're calling them now in 25 years. We'll have a whole new nosology for that.
Dr. Krusfeld, do you have anything to add?
Yeah, you know, I think, you know, that's why we're meeting, because it's so hard to communicate well. And it seems like most of us are now agreeing that the pendulum has swung too far towards nihilism, and we, I guess, as neurointensivists maybe are withdrawing life-sustaining treatment too early. And so maybe the pendulum just needs to swing into the other direction, and I'm not sure yet how long or how far. And but we need that to be able to prognosticate better and to I mean, there was, I think just last week, this paper on early withdrawal of life-sustaining treatment after stroke. And you know, we're probably doing it in just on average too early and should give more time. How to communicate that is I think, remains hard, because families, I think it was Christakis, I think, who said, families want us to be genuine, optimistic, and accurate. And that's just really hard to be all three at the same time.
But you could be highly inaccurate by pretending to be accurate in your certainty that it's not going to turn out. That's the worst kind, I think, of inaccuracy, you know, to be certain that it's not going to be a good outcome when you just don't know. I think transparency is a virtue here. And again, you know, Christakis wrote mostly about, you know, in his book on prognosis, wrote about, you know, sort of the cancer paradigm, you know, the diseases where we have so much more data and we understand outcomes better. And we have a lot more biomarkers to know where we are on that course and that journey.
Let me just, I don't know if this is a tangent, but I was just thinking when you said, you know, the worst thing we do when we try to be accurate, maybe, I think one thing that we've also now taught people a lot is to say, I don't know, which I think is important, but we also need to be accurate about it. Meaning that we should also tell our families what we do know. And I do think that there often is something we know. For example, this is going to take a long time until I can tell you whether he's going to be independent or not. I do know that it's going to take a long time. It's going to take a long time in a nursing home, most likely. Or I might even be able to say that, independence seems very unlikely in this particular case, maybe especially in an older person. So just also remembering that we also need to be accurate when we talk about, I don't know. And I think it's a very important sentence to say.
Well, looks like there's another good question. We try hard to prevent early withdrawal of life-sustaining therapies, but have seen and heard nihilistic projections by colleagues too many times. How can we teach our colleagues who are so strong-minded to stop using nihilistic nudges, comments, etc., and model better behavior to residents and other learners? Are there workshops? We talk about it a lot in neurocritical care, and this is something talked about at surgical conferences.
Well, I think one way, just like every family meeting needs a huddle, needs a pre-meeting huddle. That would be one just practical idea, and so the surgeons need to be part of that. We had a surgeon on this panel even who felt, but anyway, everybody needs to be part of that. I think sometimes palliative care specialists can also be nihilistic, and any consultants can sometimes be nihilistic. And so having a huddle beforehand and telling people, I really think we need more time until we can say this.
I also think there are other hospital resources like the ethics committee and the ethics consult service that might come in and neutrally kind of help to raise the various perspectives. But I think the most important thing to do before we meet with families is to have the pre-meeting with the team, the huddle, so that we don't share our confusion and our conflict, that we try to reach a consensus about where we think this patient is. And I chair an ethics committee. I will never meet with a family before I've met with the team and try to use that convening as because I think otherwise it's very unfair to families because we don't want to make them more confused. We want to provide them with our best estimate of the patient's prognosis. And I agree with Claire, and I'm sorry for the ambulance here, but it does take time, and you may not have immediate answers right away, and it may be a process that has to play out over time.
I think it's a really hard one, and it is a culture change, and it sometimes has felt easier to withdraw early because we like certainty, and that provides certainty. We also know how to, I think, how to comfort people who are grieving someone who is dying, and we don't know as well how to comfort people who are trying to live with uncertainty.
I also think evidence is helpful. I think, epidemiologic evidence about what the outcomes actually are. The 2018, AAN guidelines are helpful to share with colleagues who may not be in the field directly. Expose them to what the science has been over the last 20 or 25 years. It's been some of the most exciting science in the world. Introduce them to concepts like covert consciousness and cognitive motor dissociation, the work of people like Schiff, Edlow, and Jan Clausen. So I think, if we can engage their curiosity and appreciate, I think for me, a really big point is the phenotype does not always convey the underlying genotype. And I think if it can rouse the clinician's scientific and the trainees' curiosity, they may see the case very differently. And that might, engender more discussion and more reflection and less reflexive responses about the best thing for this patient would be is if they would pass, because otherwise they're going to suffer and they're not going to recover. I think exposing them to the science, which is not uniformly part of the curriculum in all places, and I think that's very important. especially for non-neuro ICUs. I mean, most people are going to receive their care in medical or cardiac ICUs and not in a specialized neuro ICU, where I think the problem is attenuating more because of things like curing coma and books like Stupor and Coma and the like. But outside, in mainstream medicine, I think patients may be at greater risk of a lack of practitioners who are not as up to date with the neuroscience developments.
Dr. Finz, do you want to talk real quickly or just put a plug in? I believe you're talking at the DOC conference in December for IBIA.
I am, and I'm going to talk. Thank you for. I had to remember. It's all virtual. It's all Zoom, so you have no idea when it is or where it is. But I'm going to be talking more about the civil rights and disability rights arguments in favor of a more inclusive approach to these patients, and I briefly touched on that in the context of our Zoom, but that'll be the focus of that talk.
And that's one conference. The end of that question, are there workshops at national conferences? So that's a 2-day virtual that's going to be focused on DOC. I think Dr. Edlow's speaking at that as well, and Dr. Giacino. So leaders in the field, I always feel like I have to kind of go searching specifically for those types of educational opportunities. But if you know where to look, there's usually some opportunities out there throughout the year. Nathalie, do we have another question?
Yeah, this one, this kind of dovetails actually from the last question quite nicely, I think. And the question is, how do we as frontline neurointensivists advocate for allowing more time for patients to recover when in many institutions, patients with disorders of consciousness are, after brain injury, being taken care of by non-neurologists, and they seem to be married to the idea that neurologists are able to deliver a prognosis at 72-hour mark and give the family an expectation we'll have an answer at 72 hours. So I think Dr. Finz had started to discuss this a little bit, that many of these patients are not taken care of primarily in a neuro ICU. They're in a medical ICU or, somewhere else. So what are your thoughts about that, ways that we can advocate for these patients outside of a neuro ICU?
Claire, do you want to start?
Sure. I think maybe we could argue it's our fault for providing the 72 hours, maybe a couple of decades ago or something. I think cardiac arrest is actually a good example where we as neurologists have sort of provided a certainty that actually isn't one. And so now we need to try and pedal back and say, actually, that's not the case. I also I don't know the answer to this. That's why it's hard to say, but I do think there's a way for us to be better at just saying, I don't know, because that is so unsatisfying for our colleagues, and especially our non-neurological colleagues. And because then they say, why did I even ask you? And there's so much that we do know, and maybe even also there's so much that we want to know. So please give this patient and family more time if it's really uncertain.
I would just say that one of the challenges that happens is that if you give people more time and then they're off life-sustaining therapy, families might feel trapped that, okay, now we can't withdraw care if in fact it turns out that things aren't going well. So there's a kind of a window where you remove the ventilators, and I think as Jeff and Claire said on the video, they're dependent on the ventilator, so they're going to die, and it becomes a self-fulfilling prophecy. But if somebody is off the ventilator and their brainstem is working and they're breathing and their airway is protected and they got a trach, the only thing left to remove might be the feeding tube. And so we have to spell that out in advance, because that would be the way that life-sustaining therapy would be withdrawn. And there's legal equivalents for removing food and water, since Cruzan and a ventilator. So people might feel uncomfortable about that, but they're legally equivalent. Now there are some religious traditions that look at food and water as ordinary care. And I think there you might want to bring the chaplaincy involved, early on, because you're basically maintaining life-sustaining therapy, and you're withdrawing the ventilator because they don't need it anymore, and they're on the feeding tube, and you're sustaining them to see how they're going to progress in pursuit of life and in pursuit of an outcome that would be hopeful. That seems to me as life-affirming. If in fact it turns out the patient is going to remain in a vegetative state, and that's a state that the family would not have wanted or the patient would not have wanted, then there should be an equal opportunity to remove that feeding tube. But of course that can be very contentious, and that was what Shivo was all about. So I think we need to talk about those issues in advance, because in a way it gets harder to withdraw a feeding tube than it is to sometimes remove a ventilator, given the legal issues and some of the religious and cultural connections to that.
Yeah. And I think that's where we need to be genuine, and that's where I think we need to say more than I don't know.
Right.
Because those are things that we do know. And so educating people about it, I actually can't say at this time that your loved one, whether or not your loved one will ever recover to independence. I think that's really hard to know. What I do know is that he's going to be in a nursing home for a long time. He's going to be dependent on X and Y and Z maybe, but probably not forever. And so I think those are scenarios that we can describe to people. And, these might be decisions that may have to be made at a different time. People also adapt to new disabilities and to new social roles. And all of those things are things that we know about and that require us to communicate and educate and also be there in the long run and support.
The other thing I just want to put out there, and it's the other side of the argument, but if people have covert consciousness or in their mentally conscious state, they have intact pain networks. So it's incredibly important that we're attentive to the burden that the patient is experiencing, and they may not ever be able to express their distress. The only thing you might see is dilated pupils as evidence of sympathetic drive. So I think we have to, as much as we're looking forward for these people's lives, we have to make sure that even though they appear to be unconscious, they may not be, and even though they may be unable to express their pain, they may be in pain. So whatever we do, as long as they're here with us, we have to make sure that they're comfortable. And I think that's also very, it's a sine qua non. That's a basic requirement that, however it plays out, that's an important moral and clinical obligation for us.
There is another question focusing more on ICU bedside nurses. So how do we work and counsel with other providers that are on the team, such as ICU bedside nurses who may have moral distress taking care of severely brain injured patients, especially because they are so in touch with patient families who are acutely grieving and very upset at the time?
Yeah, and the other thing that nurses see is people coming back. People they've sent to an LTAC and they come back and still haven't recovered consciousness. And unfortunately, ICU nurses are more likely to see those people come back than those who do well. And I think one way is to actually, try and get people back who do well, try and get them back to visit. So I think that's education, to acknowledge the discomfort we have with this. And then again, I think always going back to patient and family values, meaning that if we do everything we can in educating and communicating, and this family says, we want, with all the, even that 2% hope, we want to continue, then I think that helps everybody. And the nurses are sometimes they should, but can't always participate in family meetings. So telling them about what happened in that family meeting and why we are actually continuing to do this, I think is important.
Millie Solomon, who is now the president of the Hastings Center, when she was at the EDC in the early 90s, wrote an important paper about they didn't call it moral distress in those days, but moral distress. And she looked at attendings, house officers, and nurses. And it turned out that nurses and house officers had greater amounts of moral distress than the attendings, who basically were running the case, and care was comporting with their values and their sense of what was right and wrong. The nurses and the house staff were moral agents. They were sophisticated. They were involved in the team, but they didn't have a role in the decision making, and that led to moral distress. And today we call and to burnout and all the things we say today. So I think what's really important is that there needs to be, this takes a village. It's a team in the ICU and in chronic care, and nurses need to be involved in the decision-making process. They also, because they spend more time at the bedside and more time with the family, they may have information that the clinician who's kind of flipping in and out of the room doesn't know about. There may be evidence of a patient's ability to track or follow commands. I mean, the Carolyn Schnacker's paper keeps on coming to mind, right? That 41% of people with a traumatic brain injury in nursing homes who were thought to be vegetative, when further interrogated carefully, 41% were in the minimally conscious state. So 4 out of 10 times we're missing consciousness in patients. And the people who are going to notice that are families, and they're going to often be brushed aside because, no, they couldn't possibly be conscious. They came from the hospital, they were vegetative. But the nurses are also going to be in the room and have more likelihood of seeing evidence of awareness. So we need to include our nursing colleagues. They're incredibly important, and we're very fortunate that the Curing Coma campaign has nursing highly represented in our efforts, and they play a central role. We couldn't care for patients with coma without our nursing colleagues. So they need to be included and appreciated for the unique skills and information they bring to the conversation.
And I actually think, this is just an anecdote from our hospital, but I imagine that others have a similar experience. I did my residency, I think, 15 years ago, something like that. And at that time, I think both nurses were had more difficulty with supporting patients in a coma for longer. And I think also our palliative care consultants seemed more, I think it was a bit of neurophobia in there, and felt like, this is so horrible, how could anybody want this? And in these 15 years, I think a lot has happened, and nurses understand it much more. Palliative care consultants, the palliative care field has obviously changed towards, providing support, even, and improving quality of life, even when it's not about dying. But I think there has already been that move, and I think we're on the right track for that.
Nathalie, I don't know. I think we've got all of our questions answered up to this point.
Yeah, I don't see any more questions.
Yeah. I have one, because I was catching the last little bit again of what was recorded almost 2 weeks ago. And Dr. Manley and Dr. Finz was discussing how this, getting individuals with DOC the care and resources that they require to support their recovery, it's become a civil rights issue. And so do you predict, Dr. Finz, that, this could potentially, there could be a case in the future where a family, takes this up the court system, whether it's in regards to, not getting access to specialty rehab or, in-home services so that they can be in home versus an institution? Has it been brought to a higher court yet? And if not, do you predict that it will be in the future?
there have been some litigation in state courts, but I really think it belongs in the federal courts. I've been working for the last 6 or 7 years up at Yale Law School, writing law review articles, preparing for that eventuality. There is one instrument called an Olmstead enforcement, which upheld the Americans with Disabilities Act. There were no Olmstead enforcements at all during the Trump era. But I think that's an instrument retrospectively to litigate a lack of care that patients did not receive. And again, an Olmstead violation is a failure to receive services that allow you to be fully integrated into society, consistent with the ADA. We just wrote an article that's been accepted and hasn't been published yet, where we're looking for prospective mechanisms and changes in statutes in the law that would not just do what the ADA does, which is to affirm people's rights, but focuses on what Martha Nussbaum and Amartya Sen call capabilities, giving people the capabilities to achieve human flourishing. And so it's not a rights-based argument, but it's a capabilities kind of legislation, giving people access to the technologies that they need, the neuroimaging that they need, the rehabilitation that they need in real time. And one of our ideas is to model this as like kind of an adult version of the IDEA, which is used for children with disabilities, to give them an educational framework that accommodates their disability going forward. And it's evaluated every year and updated as they get older and progress and develop. The problem is it stops when you're 18, when you're out of school. And so maybe if we had an IDEA-like legislation for people after brain injury, if indeed the brain recovers like the brain develops, then maybe we should adopt an educational paradigm instead of a rehabilitative paradigm. And I've written elsewhere that we should think about rehabilitation as re-education. And that implies resources at a different time. It's not 3-hour rule. It's maybe a 10-year rule for people to maximize their potential for recovery. So yes, I'm hoping that one day there will be a case, and I've actually studied the Legal Defense Fund from the NAACP as a model. And one of my personal goals is to have some kind of legal, clinic with I'm not a lawyer, but with my colleagues up at Yale and elsewhere to serve as a resource so we could actually litigate one of these cases under the ADA. And I was honored last year there's a little piece in the Mayo Clinic proceedings that I wrote last year with Sam Bagenstos, who was the Assistant Attorney General for Civil Rights in the Obama administration, and is a disability advocate expert, and Megan Wright, my former fellow who's now at Penn State Law School, talking about disability law and disorders of consciousness. So that's an accessible piece. It's short, but hopefully the effort will be long, and we'll get a case, and maybe one day collectively, do for what brain injury with Brown v. Board did for people of color vis-a-vis education. Because I think that, we have a separate and unequal situation right now. And segregation is people are segregated in nursing homes, not getting the care they need.
That's a really interesting way to approach it with the IDEA, because I come from a family of teachers and special educators, and so there's so many resources put into place through the public school systems, right, through that act, that students get so many resources depending on their needs so that they can be successful in their academic career. That's really interesting to think about it in that way.
We don't have the school system for this, so we have to build an infrastructure, and that's where hospitals and hospices and nursing homes and maybe universities and colleges come into play. That we need to build the structures of care that sustain people after they spend $2.6 million in Jeff's hospital. The other $2.6 million should go into this as they go forward in their lives.
Well, and of course that needs to be a plug for funding more research, because we don't know I've been saying all this time we need to try and say what we do know, and we also realize how much we don't know. And, you know, is being able to, you know, explore people's values, knowing how well they are not only going to recover, but also adapt in the future. And there's just so much that we need to learn and systematically research. That is so important.
And I think at a time when our country is so divided, I think this is a thing that we can all come together around. This is not a red issue or a blue issue. This is a purple issue. It's about veterans. It's about first responders who got hurt. It's about kids who fell off their bike. It's about our neighbors who are suffering, and families that are incredibly burdened. And, you know, as the science progresses, it would be a shame if society didn't step up and apply the science and what we've learned to this population. And I think it could be a place for consensus for all of us to come together and do some common good. At least that's my hope.
Well, this has been wonderful. I, again, really appreciate everybody who took time to make this webinar happen. I personally have learned so much from it. So thank you, Dr. Finz, Dr. Crutzfeld, for coming for the Q&A session, and Brooke for helping co-moderate, and Ali for setting this up. Thank you.
Thank you.
And thanks to our attendees that sent in questions to get our Q&A started off today. Thank you, Dr. Finz, Dr. Crutzfeld, always a pleasure. We really appreciate your time.